Welcome to the introduction and review of the Woodbury EMS Rapid Sequence Induction Guideline, which may also be referred to as Medication-Assisted Airway Management, or MAM. So why are we reviewing rapid sequence intubation, and what are we going to cover? We're reviewing RSI since it is a high-demand, low-use procedure, but it can and is a life-saving procedure. You will begin by reading and reviewing our new RSI Clinical Resource Manual. Medications and dosages in the resource documentation are very specific to RSI and Woodbury and supersede any other guidelines and/or dosages. Following, there will be a short assessment to review what you've gone through. Then shortly, into the new year, there will be a face-to-face component. So let's do a quick overview of the key points related to RSI. RSI versus Medication-Assisted Airway Management, or MAM. The difference between the two is that RSI uses an induction agent. Woodbury, we carry two induction medications, amidate and ketamine. Keep in mind, some situations we may use Versed. So let's start with the basics. Etomidate is the primary induction sedative in all adult and pediatric patients for both the medical and trauma patients. One of the major contraindications for using amidate is in patients with a blood pressure less than 80 systolic and hypersensitivity. Keep in mind, you may not actually know if a patient is hypersensitive to amidate until after administration. Ketamine is becoming more popular as an induction agent of choice, specifically in the hypotensive patient and the asthmatic patient. Since ketamine increases bronchodilation, this makes it the sedative of choice for the asthmatic patient. Let's just take a second and talk about patients with a low GCS. This isn't something that's going to happen a lot, but with a patient with a low GCS, ET intubation may be accomplished with the induction agent only. The primary difference of RSI versus medicated-assisted airway management is that RSI uses an induction agent followed by a paralytic. MAM, on the other hand, may just use the induction agent. For example, you have a patient with a GCS of 5, you slide the ET blade in, and the patient has a slight gag reflex. You may be able to place the ET tube with just ketamine and not need a paralytic. MAM, or Medicated Assisted Airway Management, was a term used when RSI was considered controversial. The primary neuromuscular blocking agent, or what we commonly call paralytic, that we carry in Woodbury will be succinylcholine. Just a brief overview of some of the contraindications for succinylcholine: hypersensitivity, neuromuscular disease, hyperkalemia, burns greater than 24 hours old, penetrating eye trauma, and history of malignant hyperthermia, acute renal failure, and of course any anatomical airway anomaly that would make intubation very difficult, if not impossible. Our dosage for succinylcholine will be 2 milligrams per kilogram, and this will be for both the pediatric and adult patient. Following a successful intubation, you will want to use some type of sedation. There are a few options when it comes to sedation. Versed can be used for sedation and also helps with retrograde amnesia, but does nothing for discomfort or irritation of the tube rubbing against the vocal cords, epiglottis, etc. On the other hand, can provide both analgesia and sedation, and as a consideration for post-intubated patient. And a final note about sedation is long-acting paralytics prevent neurological assessment for a significant period of time. Using ketamines or combining benzodiazepines and narcotics for post-intubation sedation may increase the depth of sedation. You will now return to Target Solutions to review the Clinician Resource Manual. You will then retake the assessment using your peripheral brain. That is, use the resource manual as a guide to take the test again. This concludes this short review. Please return to Target Solutions to continue the assessment.